a high frequency of subjects with blood pressure greater than the 90th percentile, which is by definition hypertension in our population. So the best study looking at hypertension control in the setting of antiproteinuric agent is the ESCAPE trial, strict blood pressure control and progression of renal failure in children, a multi-center European study conducted in 1998 to 2001. And their goal was to examine the efficacy of intensified blood pressure control in addition to a fixed dose ACE inhibitor in delaying progression of renal disease in children. It was an RCT, randomized controlled trial, children aged 3 to 18 years of age with stage 2 to 4 CKD or GFR of 15 to 80 with defined hypertension greater than 95th percentile. And the intervention they received was a fixed dose ACE inhibitor, and they were randomized to either conventional blood pressure control with targets between 50th and 95th percentile, and the intensified blood pressure control with a target less than 50th percentile. The primary outcome they were looking for was time to 50% reduction in GFR or progression to ESRD. 468 patients were screened, of which 385 underwent randomization and 189 were randomized to the intensified arm, and the remainder 196 were assigned to the conventional blood pressure control. So this is their primary outcome, which shows that over the 5 years of observation, 29 or almost 30% reached the endpoint of 50% reduction in GFR or ESRD in the intensified control group versus 42% in the conventional group, with a hazard ratio of 0.65 in the adjusted Cox model, the 35% risk reduction in the intensified group. There were relatively more marked difference when they looked at subgroup analysis by etiology. There was a larger difference between glomerulopathies treated at conventional targets compared to hypoplasia and dysplasia. So what are the practice points here? Intensified blood pressure control appears renoprotective and additive to potential benefit conferred by an ACE inhibitor. And this has really helped us to rethink our targets for managing CKD in children to less than 50th percentile in children with CKD. And in the recently released KDIGO CKD guidelines, if you look at point number 2, we suggest, it's a suggestion, not a recommendation, that in children with CKD, particularly those with proteinuria, BP is lowered to consistently to achieve systolic and diastolic readings less than the 50th percentile. And the grade of evidence is 2D, which is remarkably low. Let's look at the proteinuria story. This is a cross-sectional study of the prevalence of different factors or complications in CKD. We find that up to 40% of children with CKD stages 4 and 5 have proteinuria, with increasing proteinuria with stage of CKD. In the CKID cohort, again, 76% of the cohort had proteinuria, 14% of them were nephrotic. Higher urine protein to creatinine ratios were associated with a decrease in GFR, non-white ethnicity, and glomerular disease. And in the ESCAPE trial, they saw a diminution of proteinuria in the first 6 months with a rebound over time that was sustained even in the setting of ACE inhibitor therapy. And that residual proteinuria was associated with increased probability of reaching the outcome, with higher degrees of proteinuria and higher rates of renal failure. So we're still far away from generating a heat map such as this. You may have seen this several times in the conference with GFR categories in the y-axis and albuminuria categories in the x-axis. In the guidelines, it's stated that the rationale and principles of this heat map using GFR and proteinuria to stratify risk of outcomes and progression in CKD applies to pediatrics, but the data are not available to substantiate it. So I'm going to just devote a couple of slides to etiology, GFR at birth, growth, and puberty. I cannot leave without mentioning that in a pediatric talk. This is data from the Ital Kid Registry, which I alluded to earlier. There are just a couple of simple points on this slide. This is the group of Italian children, with majority of them having congenital anomalies of the urinary tract, and they tracked when they were reaching end-stage renal disease from birth onwards. We see that where you start in terms of GFR matters in terms of progression and how fast you can reach the outcome. And the other thing to note here is that around the age of puberty, 10, 11, 12 years of age, you can see that on the x-axis, there is a significant and sharp decline in GFR, or in reaching the outcome of ESRD. So these investigators have gone on to look at the effect of puberty on renal function, and again confirming that around the time of puberty there's a significant decline in GFR and increased probability of reaching end-stage renal disease. And the factors that are operating here could be many and beyond the scope of this discussion, which include androgen hormones and rapid growth that happen at this time. So just one slide on bladder drainage and urine infections. As pediatricians, we spend so much time on this aspect of kidney disease care. We make substantial efforts to optimize drainage and minimize infection, but there is very little data to substantiate anything that we do. There's very limited data to suggest that urinary tract infections may be associated with a faster decline in renal function. So there's a tremendous opportunity here for research and improvement. So this just summarizes the various trajectories of kidney disease in children. I'll just take you through. This is age over the lifespan. There are children who are born with obstructive uropathy, have an improvement of renal function early in life, and then have a decrease before 10 years of age. Some sustain their renal function and decrease around puberty, and some are able to sustain their renal function over a longer period of time into adulthood. This essentially gives us a window of time when we can implement intervention to delay progression to CKD. At the latter part of my talk, I wanted to devote just a few slides to talk about health system factors that affect progression to chronic kidney disease. Although I have not looked specifically at chronic kidney disease, I think in my research program, I think health systems factors are a very important consideration for our patients. So that should be put in the context of a larger context of unique determinants of outcomes in children with CKD. Sorry, I'm having trouble advancing these slides. So as a pediatrician, we always think about children, and internists think about adults, but I encourage each of you to think about each of your patients in a continuum. And we joked about pregnancy all the way to aging, but it's really, in fact, as physicians, we need to think about childhood to adulthood in a continuum. So there are various provider, patient, and system-specific risk factors specific for children, particularly the cycle of CKD, the severe cognitive deficits, lack of educational attainment, poor labor force attachment, adolescence, adherence, risk-taking, and transfer to adult centers, all of which are very important in determining the trajectory. We know that graft failure, for example, in transplant patients are particularly high in the adolescent window, 15 to 25 years of age, as shown here in this graph, a peak of graft failure in the US, right in the window of time around the transfer between pediatric to adult care. This may not be relevant for many of you who care for patients from birth to death, but in the developed world, when there's a specific transfer from one center to another, this becomes an opportunity for risk. We showed that there's a twofold risk of graft failure in children who are just transferred from pediatric to adult care. And also there is an increased number of hospitalizations just immediately after transfer of care. And I just pause here to show you this kind of concept map to summarize everything that I've said, in that the underlying disease, the etiology and timing of when you get chronic kidney disease as a child feeds into morbidity and mortality and CKD progression. It affects adolescence and development. It may impact non-adherence to treatment. We have to think about adaptation to a new care model being cared for by adult physicians, loss of parental support over time, and perhaps a downward SES trajectory. All of these things affect our patients. So in summary, we discussed the unique aspects of epidemiology of chronic kidney disease in children and made you to think provocatively about what we know so far. We talked about different usual and unique factors affecting CKD progression in children, and we also put it in the larger context of what are the unique determinants of outcomes of children with CKD. And I just want to end with a couple of slides just to tell you a bit about what we do as pediatric kidney doctors. So this is diary from our kidney clinic. This patient of ours was the first transplant patient who received a kidney transplant without a bladder. She has an ideal conduit, but she's doing quite well with a number of infections. And this is just to show you our hospital where we work at the Alberta Children's Hospital in Calgary. The star shows you where it is located in Canada, beside the beautiful Rocky Mountains, an institution that's really devoted to improving child health and kidney health. And finally, I wanted to emphasize how important it is that you and I are in this together. This is a poster from our Kidney March, which is a 100-kilometer walk over 3 days to raise funds for the Kidney Foundation of Canada. And the individuals on this slide include patients, renal transplant recipients as children, their parents, and my colleagues. Together, we can make a difference for kidney disease, but it requires a lot of steps between now and then. Universally, all children and adults with kidney failure died 50 to 60 years ago, but we are so much farther ahead, and it's very important that we work together to improve care for both children and adults with chronic kidney disease. I encourage you and I applaud you for coming to these meetings and continuing to advance kidney care in the world. Thank you.
Thank you.